This is my speech on Lincoln University, Department of Neuropsychology, and it's led by the senior lecturer Julia Föcker, which I know from time before. Now I will start the Zoom session and we'll show how it goes.
Hallo.
Hello.
Hallo.
Everything all right?
Kannst du mich hören?
Ich kann gut hören, ja.
Okay,
Ich muss
super.
mal eben noch mal das Fenster zumachen, damit wir keinen Krach kriegen.
Hallo Elisabeth.
Hello, can you hear me?
Yes.
Perfect.
Everything all right?
Ich wollte noch kurz sagen, bevor wir anfangen, muss ich halt wie so einen Registrierungscode dem Studenten geben, den müssen die immer eingeben. Das mache ich kurz und dann würde ich Sie kurz vorstellen und dann können Sie auch starten, wenn es okay für Sie ist.
Mhm.
And I just wanted to say, we will record the meeting, so Elisabeth and my teacher, just to let you know that this meeting will be recorded.
Recording in progress.
Welcome everybody. Maybe you can reduce a bit now the noise level. It's very nice to see you all, and before we start today with a very exciting and interesting topic and also a very exciting and interesting guest, I would like to give you the register code for today, and that is 168107, and maybe you can indicate if that is working for you. So it's 168107. Great. Okay. Yeah, so then let's start. So today we will talk about prenatal reflexes. And I'm very excited and honored to introduce to you Ralph today. Ralph is a child and adolescent psychiatrist for over 30 years. And he is caring for families with very young children up to young adolescents and adults. And so today we will discuss here the topic of prenatal reflexes. And you are invited, of course, to ask any questions. So some of you have posted already questions in the Padlet. This is fine, of course, but please feel free also to ask here questions if you have any, and then we will answer them and discuss them here together. Ralph, maybe if you want, you can talk a bit further about yourself and about your experiences. I don't know, we can see.
Okay, I hope you can hear me all right. Thank you for the invitation. We have known each other quite a long time, and so I'm quite proud to be invited to Lincoln University. Julia made a short introduction. Yes, I'm a child and adolescent psychiatrist, but have also from the past experience with dealing with adults, and have a private practice also for adults, and they come with all kinds of disorders and complaints. And in my Dorsten practice, I work in a big team. We are 23 or 24 employees, and some of them are orthopedists dealing with movement disorders. And from them I learned some years ago to have a special regard to these prenatal reflexes, which we of course we learned in our study at university, but we did not understand up to now that they have effect later on also, not only on children but on until adult age. To understand this, you have to understand the meaning of these reflexes and that they develop quite early in the life, still in the womb of the mother. The first reflex will start to grow with 9 weeks gestation time. The first reflex is Moro reaction, and it will be able to keep the growing child safe and healthy. For example, if some bleeding occurs in the first trimesters, that's meaning the first 3 months of pregnancy, which is threatening to get the fetus out of the womb, so he will not survive. But with this Moro reaction, he can keep inside and keep on with his growth. That's just one example of reflexes which are starting to develop, originated in the cerebellum, the small brain, and there are several others to come later on. The whole number of reflexes which are important will have been completed with the 16th or 18th week of pregnancy. So then the child is able to deal with almost all bad things that may happen in pregnancy. That's the first abandonment of the reflexes during pregnancy. The second abandonment is preparing the own birthing process and help within. Obviously, you know, the normal way to be born is with the head first. So the unborn child has to move in the right position. And during the birthing process, there's the wow from above, pressing the child to the exit. And at the same time, the child has to move the head, getting through the opening, which is very small. And at the same time, there's no oxygen from the placenta because the pressure builds up to get the child out. That's that's another reflex which will help the still unborn child to survive this. This reflex is called ATNR, meaning asymmetric neck reflex. And those two I mentioned are the most important for surviving. That's why I choose the title for my book, Live or Die. It's the main question for the unborn child, to live and not to die. So these reflexes can help, and help a lot for surviving. Afterwards, when you've been born, they still have an abandonment, and they will try to prevent suffocating, for example, for a very small newborn baby when it's lying on the in a way getting no air for breathing. So one of these reflexes will start and throw around the baby to get oxygen again. So these are the main purposes why these reflexes are ingrained in our first development.
Can I ask a question at this point?
Yes, of course.
Yeah, so these kind of reflexes you mentioned develop very early, and what is the expected age that they basically disappear?
They should start to disappear, to integrate, we call it, during the first year of life. So pediatrician usually looks for these reflexes when the baby is very small in the first year, but afterwards they're not regarded by our medical professions. And we say these reflexes should be fully integrated at the age of 4.5. Yeah. The second point we are going to speak about is what happens if these reflexes will not integrate. Then they may cause emotional problems, ADHD, and several other disorders. And we will speak about examples later on, I think.
Okay. Yeah, thank you so much. Can I ask you at this point also some question? You mentioned actually some disorders at this point. So, for instance, ADHD or autism. Can you maybe describe a bit in the context of ADHD how these kind of reflexes are basically not integrated, but maybe before doing that to explain ADHD a bit further, so the characteristics, maybe so that we all know what kind of criteria is characteristic for ADHD.
I think we're hopping right in the middle of the theme, very fast. My proposal would be just to give a short description of the two main reflexes, so afterwards we can understand better why they may affect emotional stability and concentration, for example. If I may start, I will describe the Moro reaction, which is the first reflex which will develop. It's an involuntary and controllable reaction because it's triggered by the brainstem to a sudden stimulus. This stimulus can be movement, touching, and a loud noise. 3 ways to trigger this reflex. It's a sudden change in position of the head can also trigger the reflex. The reflex itself consists of a sequence of rapid movements. First, arms and legs are moved away from the body in symmetrical abduction, with the infant inhaling violently. After we brief freeze, the arms and legs are brought back towards the body in a clasping movement, and the baby exhales, often accompanied by a cry. This is described for a baby, but you are able to watch this in adults as well if they have not integrated the Moro reaction. Maybe we will see a short video later on. The release of stress hormones, adrenaline and cortisol, will be activated as well. And the sympathetic nerve system is the way how these reactions are transported in our body. I make a short jump to ADHD question. Because the Moro reaction is very often cause for impulsivity, cause for a lack of concentration. Why? If you have a still active Moro reaction, you have to control it, because otherwise you will get much negative feedback and restrictions. So you have to use a lot of your concentration to let the Moro reaction not start. So this reduces the ability to concentrate for other tasks. That's one point of explanation. Later on we will show how measurements will support these support this. Just a very short case study. We are dealing with a 9-year-old, and he's handicapped because he needs hearing aids for going to school, and he is in a class for handicaps, all affected with bad hearing. And they have hearing aids usually. They go on a school excursion and want to play in a pool, play in the water. So the teacher tells them all to put the hearing aids out and put them on a table before going down to the pool and water. And when the playtime is over, they shall walk back to the table, but that means going over leaves and twigs and some stronger branches. And the teacher, she walks just behind this 9-year-old Paul, and she wants to warn him not to stumble on a bigger branch. And she touches him from behind because she cannot shout or speak to him. He is without his hearing aids. And when she touches him, he gets startled, and the Moro reaction nobody knew about started. So he made this arm movement, and she was very near him. So the effect was the teacher's nose was broken. Afterwards, he didn't know why he did this, and he was devastated and started to weep. And it used around about 10 minutes for him to come in a normal state again. Afterwards, the description of what happened showed this was a pure moral reaction which nobody knew about. If you knew this body, a child would react in this way, you would not touch him from behind when he had no hearing aids. So
Okay.
this is just an example for how badly still persistent reflex can have an effect in normal life.
Yeah. Can I ask a question about this case?
Yes, of course.
Because you mentioned that also this controlling these kind of reflexes, but if I understand correctly, they are really automatic, so they cannot be controlled, right? As also probably seen in this child, if he could, he would probably have controlled this kind of reflex. And that's now my question. Are there any adults or any cases of people who can control these reflexes, who don't have the need, for instance, to search for help or support, but who can control them?
Most of the adults affected will not know about this. They will not know they have not fully integrated reflexes, and we're not in every case dealing with 100% active, rest active reflex, but with a lower grade. It happens, we say in percent, 100% is not integrated at all, 75, 50, 25 and 0%. The experience is when you have around about 25% rest activity, it's able to control quite well, and you will not be suffering. But all activities above 25 will have some kind of impact.
Okay.
I may add another case, which is quite impressive. 2 years ago, I was presented with a 24-year-old student. She's studying medicine, and she told me of her 24 years, 18 have been with a lot of anxiety and panic attacks. And she used to do quite a lot of counseling. The only thing she did not want was medication. But I was quite impressed of the way of suffering 18 of her 24 years. And when I made the first examination, we explored the reflexes also, because it's standard with my first examination, and she had a moral reaction of 100%. All the other reflexes regarded were good integrated. It was only this reflex. So afterwards we tried dual treatment, doing movement therapy, reducing the reflex, and counseling as well, same as she'd done before. And just 2 months ago, I had the chance to see her again, because she's studying in Spain and only for holidays comes to Germany. And it was quite exciting. She was able to leave the flat. She was able to go to the lectures, which she couldn't before. She couldn't even, in the start of the treatment, she couldn't even keep alone in her flat. She needed her mother coming from Germany and staying with her. And if she wanted to go out and go shopping or something, it was not possible. It was a lot of stress, and she told me she was quite lucky with the COVID-19 starting, because 3 semesters she could study online. But now with the pandemic going down, she was expected to physically be present at the lectures. So it was quite happy that we had the chance of 1.5 years doing both treatments, which made a breaking point for her. And now she's quite happy living with a friend, but with a boyfriend who's also studying medicine, and she is able to attend all the lectures and so on. Is doing quite well. She is not without anxiety, but the panic attacks are a lot better to get on with, and she had not needed medication at all.
Okay, that's very impressive, I have to say. I don't know if you would like to talk a bit more about this therapeutic approach now, because of course we would really like to know how this can happen now, right? That she loses this kind of panic attack. So what kind of procedures you suggested there for her?
For her, the first thing is you have to be sure and safe in your own body. It sounds quite self-sufficient, but it isn't. When the reflexes are still active, you are oversensitive, for example, like the 9-year-old Paul in my example. And you have to get used to being touched. So one of the first things we do is importing some kind of massage, which you will do on your own body to get a better feeling and not go down with your sensitivity to a normal level. Yeah. So that's always first in our tasks, and afterwards there will start specific movement therapy sessions regarding what kind of what reflex you want to improve. They're different.
Okay.
Yeah. I don't know if you want to show some short video at this.
Yeah.
Yeah.
Yeah. I'm just checking. Just 1 second. So I will show now this burst massage, if that is okay.
Yes.
I can reduce the sound, and then maybe so that we can just see the movements. And if possible, I try to play this here now. Just 1 second.
Die Bürstenmassage zur taktilen Stimulation. Diese weiche Bürste beginnt an der Hand, immer von den...
Sorry, I will just do here thing. So I'm sharing this now, and so this is now this procedure I think you recommend as a first approach. Could you describe a bit, I mean, is this recommended for children, for adults, for everyone basically, or are there any more specific cases where you recommend this, or is this a general approach you recommend for everyone at the beginning?
this is a general approach for everyone, children as well as adults. It contains a brush which has two sides. It's one side is very smooth and the other is a bit rougher. If you are hypersensitive, maybe in the first goes you are so sensitive that it will irritate with the smooth side. So then you have to change to the other side of this brush, which is rougher and better to identify for your own body.
Okay, and so the main aim of this, you mentioned that, is also to get a bit more sensitive and experience your body much better, if I understand that correctly, right?
A normal sensitivity, not the hypersensitivity we start with, usually.
Okay. Okay. Yeah, so...
Yes, I think that just for the first impression it's enough. Maybe I can explain with this 24-year-old student. In the first examination, we spoke about what I wanted to do. I wanted to explain the first movement therapy, which she had to do at home, and I declared I wanted to touch her from behind. She knew what was going to happen, and I just lay my finger on her back, and she started with the moral reaction. She could not control it. It was impossible.
Oh.
And 1.5 years later, she was able to go into contact and not react this way.
Okay.
It was able to reduce the activity of this reaction from 100% to 25% in the last examination.
That's impressive. I mean, I'm just wondering, when I think now about this, so that there is this kind of automatic moral reflex when you touch, for instance, the patient at the back, and then suddenly it is, or not suddenly, but by this therapy it is reducing. How would you explain, does this therapy work actually, so that the reflexes reduces? I'm just wondering how this kind of sensitivity can have such an impact on that the reflexes is reducing. So, how can one explain that?
Usually in our genetic program, the reduction and of these reflexes is ingrained. It's just stopped because the body has made an experience being of near death and having to use these reactions to survive. That's the explanation why the integration will not follow the usual process. But to understand more about the emotional impacts later on, it's important to tell you something about the second survival reflex, the ATNR, which is, I might do now, if it's okay.
Of course,
yes. The ATNR uses the other main nerve system. We have the sympathetic nerve system and the parasympathetic nerve system. Yeah? The nerve systems are used by these reflexes. Yeah? So if you remember, maybe in your training, the sympathetic nerve system will activate pulse, blood pressure, the movement muscles, will activate all this, and adrenaline and cortisol, etc. And the parasympathetic is the antagonist. it will put the blood pressure down, pulse down, and relax these muscles. So when the 18-hour reaction starts, the blood pressure goes down. It may be like a syncope. Yeah, you lose the blood pressure and have some minutes of not being conscious. It's not dangerous for life. It's a way of the body to spare oxygen, and it will start in the body or during the birthing process, for example, when there's less of oxygen. So it's a kind of survival modus, but the other way around, not starting everything and pushing up, but going down like a small winter sleep. Yeah.
Okay.
Yeah. So when I explain this to my patients, I call it it's the brake pedal and the accelerator, like in a car. When you're in a dangerous situation, you can choose in a millisecond if you want to go full power to get away of the dangerous situation, or brake hard and stop as well as possible. So the body is able to do the same. It can choose in a life-threatening situation to brake or accelerate. Yeah, and the 18-hour is like a brake, and the Moro is like the accelerator. So it gives a bit better understanding what's happening in the body. I will tell you a little example of the 18-hour. It happened in our examination with a orthopedist. It was Emily, 14 years old, suffering from anxiety and panic attacks also. And she was put on a board with rolls beyond. She stood on this board and quite stable, but the orthopedist threw her around 100 degrees, not very fast, but just turned her around, and this was sufficient to start the 18-hour. Then I was called from my room next door, and we had to deal with her blood pressure going down and her being unconscious for 2 or 3 minutes, because these strong 18-hour reaction had been shooting in. If we'd known it, we'd have not done this kind of examination.
Okay.
So
yeah.
This is an example for how unpleasant the reaction will be if it happens not in a planned and safe surrounding. And the consequence is these people have to control her surroundings and avoid everything which might cause the reflex to start.
Okay, yeah.
And later on, when you have a new patient and get the first examination, and you have both reflexes active, the measurement, which of them, Moro and 18-hour I'm talking about, the higher one will be the cause of what you do to prevent the reflexes starting. The dominant one.
Yeah. Yeah.
For example,
okay.
if Moro is 75% and 18-hour 50%, your measurement, your kind of behavior will be dominated by the Moro reaction, and the other way around if 18-hour is dominating. Yes?
Can I just ask one other question about this? So that means both reflexes can occur in the same patient, of course, right? So it's not only that there is a predominance always of one reflex, it can be also that the other reflex can occur at the same level.
Not at the same time, but
not at the same time, of course, but they can occur in one patient.
That's right, yes. And we're just today, just for teaching reasons, we're talking about the two main reflexes. There are a lot more. Yeah? Maybe I can answer the question Sam put in, which would be quite good at this moment. I'm just reading from his question. Sam wrote, "For my thesis, I'm looking at prenatal maternal stress, anxiety and depression as a predictor of children's behavioral problems in later life, specifically some of the conditions mentioned. Whilst there's a lot of work that has been done on infants and younger children, the literature is very much non-existent when it comes to older children of early to mid-primary school, age 4 to 7. I was wondering whether stress, anxiety and depression would have an impact upon the baby's reflex development before it's even born, which could potentially contribute to the conditions reported in my chosen sample." I think, Sam, you're absolutely right. That's one cause we see quite a lot when the pregnant women are under a lot of stress, family stress, personal stress, health stress, and so on. It will affect the unborn baby. The unborn baby is nurtured via umbilical cord, and it will get all these stress hormones the mother is producing when she is under stress. The baby will not be able to decide if this stress is right or wrong, but it will just do the same as the mother. And when the first reflexes have developed, so the mother has stress and the baby activates moral reaction. Later on, when the baby is a bit older in the womb, it will also produce hormones, but the first reaction is on the reflex level. So yes, Sam, stress in pregnancy may produce very high activated moral reaction, which has later on difficulties to integrate. And it's not only for children and primary school children, but my examples showed it may keep on affecting the life of adults and also older adults.
Yeah, thank you so much. There was another question on the Padlet. I don't know if the person would like to ask that in person. I can also ask this, of course. So there's a question: is it plausible to suggest that poor reflexes may lead to ineffective muscular control and decreased muscular development or hypotonia?
Sometimes hypotonia is correlated with these reflexes, but only if the reflexes have not been able to protect fully. Yeah, you see, when there's oxygen deficiency and the reflex goes on, maybe it's too much. So then some damage will be done. And although the reflex is doing what it can, there may be hypotonia as effect of all this.
Okay. Yeah, thank you. So I would like now also to give you all the opportunity online and here face to face to ask any questions. If you want, I don't know, does anyone have any questions which you would like to ask also online, of course? I would like to know if possible, how you would differentiate, I mean, this pattern of reflexes from other motor tics or from other, so that we know that there are cases where people also have some motor tics. I don't know how to describe that, but how are you able to differentiate that from other diseases?
The movement patterns of reflexes is the same.
Yeah.
It's another movement than tics produce, but of course there's a connection on the stress level. When the reflexes are not integrated, the stress level of your body is much higher, and we know that higher stress may get out or produce tics if you have a genetic disposition. In the beginning of our talk, there was the question about ADHD and persisting reflexes. Maybe we could show just one case from Alexander, 8 years, because we have some examinations about his concentration, which changed under our treatment, which could be quite interesting.
Yeah, I'm just sharing that here as well. Just 1 second. Oops.
Okay, you're looking for the picture, and I'm talking about this Alexander. He's 8 years old when I saw him first. The mother described in the first interview that he has extreme aggressive impulses for no apparent reason. He screamed loudly, threw objects around, or completely trashed his room. 35 minutes later, he usually complained about breathing problems and could then regulate himself down. Afterwards, he felt very sorry, often cried. That's a typical Moro reaction. The single mother was heavily burdened by this situation and already had to seek psychiatric help for herself. The case history showed there was preterm labor from the 30th week of pregnancy onwards, followed by an emergency cesarean section in the 34th week of pregnancy. When the baby's heart tones dropped, that was activation of 18R, and he used to have intensive postnatal monitoring for 6 weeks. He weighted 1,750 grams, indicating oxygen deficiency during pregnancy, because he was very small for date, even from the 34th week. He had a length of 43 centimeters, and further early childhood development was described as unremarkable. The first reported abnormalities began with school enrollment. Our reflex status in the first examination was as follows: 18R 75%, Moro 100%, STNR 75%, and some lower levels of other reflexes. He was normal intelligent, IQ 94, and now we can have a view on the first slide, figure 1. Figure 1?
Yeah.
Okay, this is the Opatus test report from beginning of the treatment, and it's a concentration test for 16 minutes. You can see the minutes on the low line. Okay, he sees 2 targets. It's a target and a non-target on the screen. The screen is the screen of an iPod. If he presses right on the target, it's a green circle. If he presses on the non-target, it's a red dot. And if he has made omission errors. It's a red circle on the low line, and above you realize a blue line which is getting higher to the end. It is the movement, right? This is movement. So in the first examination we see a lot of impulsivity, red dots, and hyperactivity in the first case. And afterwards we did this reflex program, and you may show the second figure, which shows quite a difference. If you regard the red dots, you will see they went down to a normal level. Hyperactivity is still present, but not as much, and the omission errors are normal and only in the last minutes.
Yeah, thank you so much. That's really impressive. I mean, when one looks at the figure, how these errors also are reduced in the performance.
Yes.
Can I ask another question about this case and about the treatment?
Yes, sure.
Your treatment is more on tactile perception. But we know also when, for instance, we are in a very stressful situation, there are also other sensory systems which can evoke a stress reaction. For instance, the olfactory system, when we smell something what we remind was very stressful maybe in the past, or any noise. So do you think also that, I mean, this is now just a question, that this integration of the different sensory modalities and in reference also to body perception, that this could be also an important component? Because I understand that the reflex itself is a motor response and probably also related with the body, with tactile perception, but there are much more senses, right? So I'm just wondering how you would actually discuss this.
It's an extra lecture. We spoke about the acoustic impulses as a possible trigger. We spoke about movement and touching as trigger, and as well, smelling and all our other senses may be a part of this. It will mix with our genetic pool. There are quite a lot of differences in people. We say today around 20% of the population, they have a hypersensitivity in 1, 2 or more senses, which is normal and not usually connected with persisting reflexes, but it's a genetic path. So we have to differentiate being hypersensitive in one of our senses and having persistent preborn reflexes. They may mix, but not in every case the reflexes will be active in a person who is hypersensitive.
Okay.
Yeah.
Okay. Yeah. Thank you. Thank you so much. We are almost also at the time to sum up a bit and to answer maybe also final questions. Is from your side, do you have any other questions or any other comments for this topic? Any, I don't know, Elisabeth or Tutze, if you have any questions?
No, thank you very much.
Maybe, there's one, maybe I don't, yeah, okay, Elisabeth. So maybe just one last question. So we didn't talk too much about autism, but is that also a disease where you can find this kind of reflexes or the persistence of these reflexes?
That's right. In my last book on autism, I put two cases into the book, which we treated with a movement treatment when the reflexes had been persistent. And of course, they were some Asperger cases with a very light form of autism, but they could be fully cured.
Okay.
So it's quite impressive, and the connection is the stress level and the intensity of ATNR being present, because ATNR, to prevent the action of the reflex, you have to move and behave like somebody having autism. So it can be mixed, and sometimes the first diagnosis of autism might be not correct. But in my book, I write about pre-diagnosed autism, two cases where the treatment of the reflexes was sufficient to reduce the symptomatology. So afterwards, there was no autism present anymore.
Okay. Yeah, thank you. Thank you so much. Just for you to let you know, we will discuss also some of the cases in the seminar. And we will also have a look at some of the videos which Ralph mentioned today also in his talk, just to give you a further idea how these reflexes are demonstrated also or seen in adults. And yeah, I would like to thank you a lot, Ralph, for the discussion and for sharing this very interesting ideas, very interesting experiences. I find it extremely interesting. So thank you so much for being here today with us and sharing this information. And of course, we will keep discussing about this now in the seminars. And who knows, maybe we also find some interesting research ideas about this topic. So that is a very nice starting point, and I appreciate a lot your time. So thank you so much. Thank you.
Thank you.
Thank you. Thank you. Bye.
Bye.
Thank you.